Hello, my family. Hello, and welcome to our topic lesson. Our topic lesson is the most important lessons, which is lower respiratory tract infection. The first one and the most common lower respiratory tract infection is pneumonia. First of all, we should have to know the definition of pneumonia. Pneumonia is inflammation of the lung parenchyma. This is the definition of pneumonia, and that is the leading cause of this globally among children less than 5 years of age. Therefore, it is most common disease that can cause this for the children less than 5 years. Pneumonia account is 920,000 deaths of children less than 5 years annually. More than 99% of pneumonia deaths are in low and middle income countries. The highest pneumonia mortality rate occurring in poorly developed countries in Africa and South Asia. When we come to the epidemiology of the diseases that can cause mortality, the first and the most common is pneumonia, 33%, and the second one is diarrhea, 19%. And the third one is neonatal sepsis, which most common for the neonates, especially for the children younger than 1 month, and leading by other infectious diseases. In the United States, pneumonia mortality in children less than 5 years are declined by 97%. This decline is due to introduction of antibiotics, vaccine, and the expansion of medical insurance coverage for children. This decline is due to introduction of antibiotics, vaccines, and the expansion of medical insurance coverage for children. Haemophilus influenza type B was an important cause of bacterial pneumonia in young children, but became uncommon with the routine use of effective vaccines. Due to the vaccines, it is uncommon cause of pneumonia, but it is most common cause of pneumonia earlier to this. Now it is uncommon cause of pneumonia due to antibiotics and vaccines for the children. Okay, measles vaccine greatly reduce the incidence of measles-related pneumonia disease in developing country because the measles is one predisposing to the pneumonia. Measles vaccine is greatly reduced the incidence of measles-related pneumonia disease in developing country. Improved access to the healthcare in rural areas and of developing countries and introduction of pneumococcal conjugate vaccines were also important contributors to the further reduction in pneumonia-related deaths achieved over the past decades. Okay, when we come back to the etiology of pneumonia, we can classify the etiology of pneumonia into two: non-infectious and infectious causes. Non-infectious causes are aspiration. It may be food or gastric acid, or it may be foreign bodies, hypersensitivity reaction, and the drug or radiation-induced pneumonitis. Those are the non-infectious etiologies for pneumonia. And also the other one is infectious causes, which is most common. And we can classify the infectious causes depending on the microorganisms. It may be bacterial, fungal, viral, and parasites. What are the risk factors for pneumonia? When we say lack of exclusive breastfeeding is the most risk factors for pneumonia due to leading to the malnutrition. The second one is undernutrition, indoor pollution, low birth weight, crowding, lack of immunization, and the others are the risk factors for pneumonia. Etiology depends upon ages, clinical settings, local epidemiology, relevant exposure, immune status, and the immunization status. Those are the risk factors for etiology. It is mostly common for the younger children and the older age. That is, the age is risk factor for pneumonia. Clinical settings, it may be community acquired or hospital acquired or health institution acquired. That means when we say community acquired, if the pneumonia causative agents are acquired from the community, we can say community acquired. If it is acquired in the health institutions, you can say health institution pneumonia or hospital acquired pneumonia. And also local epidemiology, respiratory syncytial virus, influenza epidemics, and the other infections that can lead to the pneumonia. Relevant exposure such as contaminated water, animals, and the others. Immune status is the risk factors. Immunocompromised children are at risk of pseudomonas species, and the immunization status of the children is the risk factors for the pneumonia. And when we see the infectious causes of pneumonia one by one, it may be, as we said earlier, it may be bacterial, viral, fungal, and parasite, and archaetia. When we see the bacteria, the most common are Streptococcus pneumonia, group B, Streptococcus group A, Streptococcus, and Staphylococcus aureus are the most common. And there is atypical bacteria that can cause pneumonia, such as Mycoplasma pneumonia, Chlamydophila pneumonia, Chlamydophila trachomatis, and the others. Those are the most common bacteria that can cause pneumonia. The second most common infectious causes for pneumonia are virals. The common viral causes of pneumonia are respiratory syncytial virus, parainfluenza types 1 up to 4, influenza virus A and B, and adenovirus are human metapneumoviruses are the most common causes of pneumonia. And the other one is fungal pneumonia, Histoplasma capsulatum, and Blastomitis dermatitis are the most common causes of for pneumonia from the fungal. And the others, there is so many infections that can cause pneumonia, but the most common from bacteria, from viral, and from fungal are those ones. And the cause of pneumonia in an individual patient is often difficult to determine because the first one is direct culture of lung tissue is invasive and rarely performed. The second one is cultures performed on specimens obtained from the upper respiratory tract. But the pneumonia is the most diseases that can cause lower respiratory tract infection. Streptococcus pneumonia is the most common bacterial pathogens in children 3 weeks to 4 years of age. This is what we call S pneumonia or pneumococcal. The most common cause of the pneumonia for the children between 3 weeks up to 4 years of age. Mycoplasma pneumonia and Chlamydophila pneumonia are the most frequent bacterial pathogens in children age 5 years and older. This is what we call atypical bacteria. The atypical bacteria are Mycoplasma pneumonia and Chlamydophila pneumonia, which is most common cause of pneumonia for the children older than 5 years. Staphylococcus aureus pneumonia often complicated an illness caused by influenza viruses. Streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus are the major causes of hospitalization and deaths from bacterial pneumonia among children in developing country. As we said, we can classify into community acquired and hospital acquired. And the most common severe that can lead to hospitalization are the most serious species. The first one is Streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus are the major causes of hospitalization and death from bacterial pneumonia among children in developing country. Viral pathogens are prominent cause of lower respiratory tract infection in infants and children older than 1 month but younger than 5 years of age. Of the respiratory viruses, respiratory syncytial virus and rhinoviruses are the most commonly identified pathogens, especially in children younger than 2 years of age. From the viruses, those two viruses are the most common causes of pneumonia, which is respiratory syncytial virus and the rhinovirus. Other common viruses causing pneumonia include influenza virus, parainfluenza virus, adenovirus, enterovirus, and the human metapneumovirus. Children who are immunosuppressed or who have an underlying illness may be at risk for specific pathogens such as Pseudomonas species. Or we can classify the etiology of pneumonia by ages. First one is for the neonates. Which infection or which infectious agents are most common for the specific ages when we say for neonates or less than 3 weeks? GPS or group B streptococcus and the E. coli other gram-negative basis pneumonia H influenza type B are the most common infections for the neonates pneumonia. The second one is for the children aged between 3 weeks and 3 months, respiratory syncytial virus and other respiratory viruses, Streptococcus pneumonia, Haemophilus influenza type B. If patient is febrile, consider Chlamydia trachomatis. 4 months to 4 years, 4 to 4, 3 to 3, 4 to 4. For 4 to 4, respiratory syncytial virus, other respiratory viruses, Streptococcus pneumonia, Haemophilus influenza type B, and Mycoplasma pneumonia group A Streptococcus are the most common pathogen, the most common causes for pneumonia for the children between 4 months up to 4 years. The third one is for the children older than 5 years, Mycoplasma pneumonia, Streptococcus pneumonia, Chlamydophila pneumonia, Haemophilus influenza type B, influenza virus, adenoviruses, and the other respiratory viruses are the common causes for pneumonia. Okay, when we come to the pathogenesis, how those infections can cause pneumonia. The first is there is a defense mechanisms of respiratory tract, mechanical, innate, and adaptive defenses. The mechanical defenses are filtration by hairs and turbinates, mucociliary clearance, gag reflexes, and the cough. Those are the mechanical defense of the respiratory tracts. The second one is innate defense, airway antimicrobial factors, alveolar macrophages, and the neutrophils are innate defense. And also there is adaptive defense, such as secretory, IgA, and IgG. Those are defense mechanisms for respiratory tract infection. How it can cause pathogenesis when we say how the infection can bypass those defense mechanisms. Okay, the lower respiratory tract is normally kept sterile by physiologic defense mechanisms, as we said earlier, including mucociliary clearance, the properties of normal secretion such as secretory, immunoglobulin, and the clearance of the airway by coughing. Immunologic defense mechanisms of the lungs that limit invasion by pathogenic organisms include macrophages, that are present in alveoli and the bronchioles, secretory IgA and the other immunoglobulins. Those all are the mechanical defense of the respiratory tracts. Okay, the viral pneumonia pathogenesis. How the viral infections can cause pneumonia. When we say usually results from spread of infections along the airways accompanied by direct injury of the respiratory epithelium. It directly injures the epithelium of the respiratory tracts, which results in airway obstruction from swelling, abnormal secretion, and the cellular debris. When it is directly affected, it is responsible for these injuries by secreting abnormal secretions, cellular debris, and it may be swell. This can lead to the respiratory tract obstruction. The small caliber of airways in young infants makes such patients particularly susceptible to severe infection. Atelectasis, interstitial edema, and ventilation perfusion mismatch causing significant hypoxemia often accompany airway obstruction. Viral infection of the respiratory tract can also predispose to secondary bacterial infection by disturbing normal host defense mechanisms, altering secretion, and modifying the bacterial flora. If there is viral infections for the upper respiratory tract, usually the bacteria can follow the viral, and by these mechanisms, bacteria can complicate the viral infections of the upper respiratory tracts. And also, if the causative agent of the pneumonia is bacteria, it is safer than the pneumonia that can caused by viral agents. Bacterial pneumonia most often occurs when respiratory tract organisms colonize the trachea and subsequently gain access to the lungs. But pneumonia may also result from direct seeding of the lung tissue after bacteremia. As we said, most common ways of gaining of the lower respiratory tract is airway tracts, but it may be but pneumonia may be gained from the bacteria or systemic inflammation. If there is systemic inflammation, it may be reach the lungs and can cause pneumonia. When bacterial infection is established in the lung parenchyma, the pathologic process varies according to the invading organisms. Okay, as we said, Mycoplasma pneumonia cause for atypical pneumonia. It attaches to the respiratory epithelium, inhibits ciliary action, and leads to cellular destruction and an inflammatory response in the submucosa. As the infection progresses, slab cellular debris, inflammatory cells, and the mucus cause airway obstruction, with spread of infection occurring along the bronchial tree, as it does in viral pneumonia. This is the pathogenesis, or how the mycoplasma pneumonia can cause pneumonia. The second one is streptococcus pneumonia. It produces local edema that aids in the proliferation of organisms and their spread into adjacent portion of lungs, often resulting in the characteristic focal lobar involvement. It is usually known by focal lobar involvement. And the other species is group A Streptococcus. It results in more diffuse infection with interstitial pneumonia. The pathology includes necrosis of the tracheobronchial mucosa, formation of large amounts of exudates, edema, and local hemorrhages. This is the most severe cause that can cause local hemorrhages with extension into the interalveolar septa and the involvement of the lymphatic vessels and increased likelihood of pleural involvement. Staphylococcus aureus pneumonia manifests in confluent bronchopneumonia. It is known by the most common causes of the bronchopneumonia, which is often unilateral and characterized by the presence of extensive areas of hemorrhagic necrosis and irregular areas of cavitation of the lung parenchyma, resulting in pneumothoracic emphysema or at times bronchopulmonary fistula. This is the most common that can usually complicate to the bronchopulmonary fistulas, pneumatoceles, and emphysema. Recurrent pneumonia. What's recurrent pneumonia? When we say if the pneumonia is 2 or more episodes in a single year, or 3 or more episodes, either with radiographic clearing between occurrences. Okay, differential diagnosis for recurrent pneumonia from hereditary disorders, cystic fibrosis, and sickle cell disease, from disorders of immunity, HIV, from the anatomic disorders, lobar emphysema, gastroesophageal reflux, foreign body, tracheoesophageal fistula, bronchiectasis, and aspiration are the differential diagnosis for recurrent pneumonia. When we come back to the clinical manifestation, how the patients with pneumonia can manifest. Pneumonia is frequently preceded by several days of symptoms of upper respiratory tract infection, typically rhinitis and a cough. When we say pneumonia, it can manifest the upper respiratory tract symptoms such as rhinitis and a cough before starting pneumonia. In viral pneumonia, fever is usually present, but temperature are generally lower than in the bacterial pneumonia. In both of the viral and the bacterial pneumonia, there is a fever, but if the causative agent for pneumonia is the viral, the fever is usually lower than the pneumonia that can caused by bacteria. Tachypnea is the most common presenting features. Increased work of breathing accompanied by intercostal, subcostal, and supraesternal retraction. Nasal flaring and the use of accessory muscle is common. That is what we call respiratory distress symptoms. Those are the clinical manifestation of pneumonia. The first one is fever. The second one is tachypnea. The third one is respiratory distress syndromes such as intercostal, subcostal, and supraesternal retraction and the nasal flaring. And the others is use of accessory muscles are the clinical manifestation of the patient is with pneumonia. Severe infection may be accompanied by cyanosis, lethargy, especially in infants. If the pneumonia is severe, it may be manifest as cyanosis, lethargy, especially in infants. Auscultation of the chest may reveal crackles and wheezing. Auscultate from the chest is crackles and wheezing for the patients with pneumonia. Bacterial pneumonia in adults and older children typically begins suddenly with high fever, cough, and chest pain. Splinting on the affected side to minimize pruritic pain and improve ventilation is noted. Such children may lay on one side with the knee drawn up to the chest to relieve the pains. Physical findings depending on the stage of pneumonia. Early in the course of illnesses, diminished breath sounds, scattered crackles, rhonchi are commonly heard over the affected lung fields. With the development of increasing consolidation or complication of pneumonia such as pleural effusion or emphysema, dullness on percussion is noted and the breath sounds may be diminished. If the patient is developed consolidation or complicated of pneumonia, there is a dullness on the affected parts of the lung. A lag in respiratory excursion often occurs on the affected side. Abdominal distension may be prominent because of gastric dilation from swallowed air or illness. Abdominal pain is a common in lower lobe pneumonia. The liver may be seen enlarged because of downward displacement of the diaphragm, secondary to hyperinflation of the lungs or superimposed congestive heart failure. If there is pneumonia, it may be complicated to the congestive heart failure and it may be displace the diaphragm downward. Due to this, it can cause abdominal distension and abdominal pain. Diagnosis and investigation. Diagnosis is clinical, but investigation are supportive for diagnosis. When we say it is clinical, we can diagnose depending on the history and the physical examination of respiratory system. We can diagnose depending on the history and the physical examination of the respiratory system, but investigation is most important and supportive for our diagnosis. The most common investigations are chest X-ray, an infiltrate on chest radiograph supports the diagnosis of pneumonia. Infiltration on the radiograph of the chest is supportive for the pneumonia. The film may also indicate a complication such as pleural effusion and emphysema. If we see on the chest radiograph effusion or emphysema, we can suspect it as there is complication of the pneumonia. Therefore, the chest X-ray is very important to identify the pneumonia as it is severe or not, or complicated pneumonia. Viral pneumonia is usually characterized by hyperinflation with bilateral interstitial infiltrates. It is known by hyperinflation. Confluent lobar consolidation is typically seen with pneumococcal pneumonia. That is most common cause of pneumonia. It is known or confluent lobar consolidation. If we see consolidation on the radiograph, we can suspect that the causative agent for pneumonia is bacteria. The second investigation is CBC. In viral pneumonia, the white blood cell count can be normal or slightly elevated, but is usually not higher than 20,000 millimeter mercury with a lymphocytic predominance. If the causative agent for the pneumonia is viral, it is lymphatic predominance. Bacterial pneumonia is often associated with an elevated white blood cells in a range of 15,000 to 14,000 millimeter mercury and the predominance of neutrophils or granulocytes. In the pneumonia that can caused by bacteria, the neutrophils or granulocytes are the predominant, but for the viral, the predominant one is lymphocytes. The definitive diagnosis of viral infection rests on the isolation of virus or detection of the viral genome or antigen in respiratory tract secretion. The definitive diagnosis of bacterial infection requires isolation of an organism from the blood, pleural fluid, or the lungs. Therefore, we can investigate depending on the organisms as it is, or bacteria, either bacteria or viruses. The second one is chest ultrasound, pleural fluid analysis, and the others. Classification of pneumonia. How we can classify pneumonia? When we said based on anatomy, we can classify lobar, broncho, and interstitial. And the second one is site of acquisition, community acquired pneumonia or hospital acquired pneumonia. Etiology, we can classify into viral, bacteria, fungal, and non-infectious. Severity used for clinical or treatment purposes into severe pneumonia, pneumonia, and no pneumonia. The other one is treatment. Treatment principles include appropriate antimicrobial therapy. We should have to identify the causative agents for the pneumonia. After identifying the causative agents of pneumonia, we should have to treat depending on the causative agents by antimicrobial therapy. The second one is encourage feeding via nasogastric tube if the patient is in distress, and increase fluid intake or increase fever. If there is fever, we should have to treat by antipyretics. And the other one, and the most important, is oxygen supplementation. Okay, the other one is a classification of the pneumonia depending on the severity of the sign and the symptoms. We can classify into three: severe pneumonia, pneumonia, and non-pneumonia. For the severe pneumonia, when the oxygen saturation is less than 90%, or if the patient is with central cyanosis, when the patient is on severe respiratory distress, such as grunting, very severe chest indrawing, and if the patient is the signs of pneumonia with a general danger, such as inability to breastfeed or drink, lethargy or reduced level of consciousness, and the convulsion, if the patient is with those three symptoms, we can say severe pneumonia. The second one is when the patient is with fast breathing. That means if the patient is greater than 50 breaths per minute in children aged 2 months to 11 months, and if the respiratory rate is greater than 40 breaths per minute in a child aged between 1 to 5 years, and the chest indrawing. Those are the symptoms of the pneumonia. And the third one is non-pneumonia. If the patient is no sign of pneumonia or severe pneumonia, only with a cough or cold, you can say no pneumonia. Depending on those signs and the symptoms, we can treat pneumonia. For severe pneumonia, you can admit to the hospital, give oxygen if saturation is less than 19%, manage airway as appropriate, give recommended antibiotics, treat high fever if present. Therefore, we should have to treat by this mechanism. If oxygen is needed, we should have to give oxygen, airway appropriate, give antibiotics, and if the patient is with fevers, we should have to give antipyretics. For the severe pneumonia. For the pneumonia, home care, give appropriate antibiotics, advise the mothers to return immediately if the symptoms of severe pneumonia, and the last one is follow up after 3 days. Those are how we can treat the severe pneumonia and the pneumonia. If the pneumonia is no pneumonia, home care, advise the mother to return if no improvement. The others and the most important is indication for admission. For the patient is with ages less than 6 months. If the patient is with sickle cell anemia with acute chest syndrome, if the patient is if the pneumonia involving multiple lobes or multiple lobe involvements of the pneumonia, if the patient is immunocompromised state, toxic appearance, moderate to severe respiratory distress, requirement for supplemental oxygen, complicated pneumonia, dehydration, vomiting, or inability to tolerate oral fluids or medication, no response to appropriate oral antibiotic therapy, and if there is a social factors such as inability of caregivers to administer medication at home or follow up appropriately, those are the indication for admission for the patient is with pneumonia. If the patient is with those symptoms, we can admit to the hospital and treat. Prognosis. Typically, patients with uncomplicated community-acquired bacterial pneumonia show response to therapy with improvement in clinical symptoms such as fever, cough, tachypnea, chest pain within 48 to 90 6 hours of initiation of antibiotics. Within 2 to 3 days, they must respond for the treatment if the patient is with the pneumonia, which is not complicated. Radiographic evidence of improvement lags substantially behind clinical improvement. If the patient is not responsive within 3 days, we should have to suspect those things. The first one is we should have to suspect the complication such as emphysema, bacterial resistance, non-bacterial etiologies like viruses or fungi or aspiration of foreign bodies or food, bronchial obstruction from endobronchial lesion, foreign body or mucus plugs, pre-existing diseases such as immunodeficiencies, ciliary dyskinesia. We should have to suspect those things if the patient is not responsive within 2 to 3 days. And the other one is other non-infectious causes, including bronchiolitis, obliterations, hypersensitivity pneumonitis, eosinophilic pneumonia. A repeat chest radiograph is the first step in the determining the reason for delay in response to treatment. And the last one is complication. If we cannot treat, how it is complicated or what are the complications for pneumonia. We can classify into two, local and distant complication. The local complications are pleural effusion, emphysema, pericarditis, and the distal complications are meningitis, suppurative arthritis, osteomyelitis. That means if there is a pneumonia, it may be cause systemic diseases. That means distal complication. If you like this video, please support me by subscribing, like and share. Thank you for watching.